good evening, everyone. I'm going to share my presentation. So now I'm going to present my case, what I have felt during what problems I have felt during the primary angioplasty of the RCA. So it was the 71-year-old male presented to the emergency with a complaint of sudden onset chest pain relating to the left shoulder. ECG is suggestive of the ST elevation into 3 AVF, and by ECG, we can predict that it is the culprit artery will be the RCA. And 2D echo also shows the hypokinetic inferior wall, and patient was the known case of hypertension with history of the chronic smoker. So we done the angiogram. First, we done the angiogram on the left side, which shows that there is a significant lesion in the LCX, and there is a moderate lesion in the and that shows the RCA showing the RCA angiogram showing that the ostial lesion is there, along with the mid lesion, which is a subtotal occlusion with the thrombus there. What we got after the angiogram of the right coronary artery, that we see that there is an ostial lesion which seems to be very tight, and there is also a lesion subtotal occlusion in the mid RCA having the thrombus there. So what we thought that might be it is due to the spasm of the ostia, which seems to be like a tight lesion. We have given the nitroglycerin to the RCA, but the lesion remained the same. So now we have to deal with the two lesions. One is the ostial tight lesion, and second is the thrombotic lesion in the mid RCA. So what I have done, first I thought there might be a difficulty in taking the stent directly to the mid RCA. So I decided to pre-dilate the ostial lesion with 2.5 into 12 NC balloon, so that it will be easier for me to take the hardware into the mid lesion. So while wiring the RCA, after pre-dilating the ostial lesion, we have this flow into the RCA, which is TIMI2 flow. And now I have decided that I will directly stent the mid RCA because we were lacking thrombustor here in our peripheral center. So we directly stent the RCA in the mid part with the 3.5 drug eluting stent, everolimus eluting stent, 3.5 into 23 at 10 ATM. So we deploy the stent there, and then so what happened after deploying the stent, that there is a no reflow into the RCA, and this flow has been stopped proximal to the stent. So what I have thought might be dissection has been occurred, or there may be some reason for the no reflow. So after that, when the no reflow has occurred, the patient had significant bradycardia with hypotension. So we decided to put the patient on the TPI and also put the inotropic support. After that, to restore the flow into the coronary RCA, we use the intracoronary tirofiban around 500 microgram via balloon. We first ruptured the balloon with the needle, and then we deploy the balloon into the coronary artery, and through the balloon we have given the tirofiban. And we also use the adenosine 100 microgram for 2 times to resume the flow into the coronary artery. So this is the flow that we get after doing giving medication into the coronary artery, which seems to be fine. But in this angiogram, I am not able to see any dissection. So what I thought might be there is a shifting of the thrombus into the proximal RCA, which has caused the no reflow. After that, we deal with the proximal lesion. We deploy there the stent of the 3.5 into 15 mm at 12 ATM, and then we flare up the ostia of the RCA with the same stent balloon. And then we got the result here, and that shows that there might be some ostial has not opened up properly. So we have taken the 4 into 12 NC balloon and at around 14 ATM, and after that we got the result like this. This is of the final result which we got to the RCA. So post operation, plasty, we have given the injection tirofiban infusion for the next 12 hours, inotropic support was tapered off, and the patient was discharged in the stable condition with antiplatelet along with the vasodilator and nicorane. So about no reflow is as per the Indian data, 70% of patients develop no reflow immediately after stenting, and patient with no reflow had a higher chances of the death at 12 months. So there are many factors which can predict the no reflow in the coronaries, like thrombus burden, TIMI flow during the angiography, patient balloon time like more than 360 minutes are the independent predictors. So further, more evidences such as the female sex, hypertension, and renal insufficiency or elevated inflammatory marker are also predictor for the no reflow. So what we have to do in the no reflow, that pre-procedure we have to obtain the optimal blood pressure, optimal glycemia, good effective DAPT and statin. And during procedure, we can use the nitrates, optimal anticoagulation, anti-GP2B3A inhibitor, along with rotational atherectomy protocol if it is a calcified artery, and venous graft protocol like using the distal protection device if we are doing the venous graft. If there is a no reflow, we can use the selective intracoronary calcium channel blocker like Diljam, or we can use the adenosine. Additionally, we can use the anti-GP2B3 inhibitor and tyrofevan, like tyrofevan, or we can also use the epinephrine in that case. This is the flow chart for the coronary no reflow in the JACC published, which has told the same thing, what intracoronary drugs we can use to presume the flow. So overall, the final remark is like that: doing the primary stenting, we should avoid the high pressure stent deployment, and we can also use the thrombectomy before intervention. That can prevent the no reflow. Thank you, sir.
Yeah, thanks, Amit. So these are some of the things which we routinely face while handling the primary PCIs. Usually vessels have huge thrombus burdens, and I agree many a times we land up with slow flows or no reflows. So practically, what are the tips? As per my statements, I can give few statements where we can avoid such things. One, if the artery is 100% occluded, then still, although the data is not fully supporting the use of export catheters, but I think export catheters still do a lot of benefit in such vessels if the artery is 100%. If the artery is flowing, I'm clear that it's not giving much of the benefit. Just excuse. Yeah. So 100% occluded arteries, thrombus burden is higher. We should use export and then start the procedure. Even if it removes the 20% chunk of the thrombus, it's going to benefit the patient a lot in terms of the vessel flows. Second, if the artery is flowing, still there is a lot of thrombus. Usually, one should think of using these GP2B3A tirofiban infusions prior to starting the stenting. So 10 minutes prior to starting the stenting, I think it improves the results and it improves the vessel flows in a better manner. So usually we wake up after it starts happening, then it's of lesser benefit. But if we use it prior, and it has some dethrombi effect, it's not thrombolytic, but it has a dethrombi effect that also cleans up the vessels a little bit, and it helps in having a good patency and good flows in the vessel. Two, as you also mentioned, try not to have aggressive post-dilatation. This is very, very important. I think if we do more post-dilatations, more vigorous post-dilatation in vessels where patient is landing up with primary acute MI situation, then the more chances of more slow flow or more no reflows are more. Try to use the stent and inflate the stent at the vessel caliber size if there is not much of residual lesion come out. Obviously, I'm not stating that we should under expand the stent. So if it is a 3 millimeter vessel, take a 3 millimeter stent and inflate it at 14-15 atmospheres. Try to avoid the post dilatations at all. I am giving even a vigorous statement. So no post dilatations as far as you can handle it. If it is required, only do the residual areas with a smaller balloon and come out. So these are some of the tips, and also don't shy away of using a diluted adrenalines, epinephrine into the coronaries. We use it very frequently. 1:1000 dilution, 1 ml, 2 ml. Start keep on giving that. One, it peps up the blood pressure. It improves the flow. So this is very interesting. People tend to use it lesser, but we quite frequently use it. It's very, very productive. This is the most important coronary vasodilator we have. We tend to forget. We keep on giving nitroglycerins. You can't give. The patient has gone into hypotension. Then you are looking at adenosine or diltiazem. Again, you can't give because of bradycardia. So what you are left with? I always tell my staff in the cath lab, or keep the adrenaline ready to be diluted if at all we'll end up with no reflow. So these are some of the tips to avoid or handle the no reflow. Kunal, one word from you.
So I think so this case really highlights the role of thrombustor device in acute MI. So if we have a good thrombus burden, ideally it should be used prior hand. And one more thing, when he encountered no reflow, the thrombustor device is a very good device for the distal delivery of the drugs. So ideally it should be also always available in a cath lab when we are doing acute MI cases. And one more thing, sir, which I want to ask from you. So in our practice, what we are doing once we encounter no reflow, the one thing which we find really helpful is repeated saline flushes, and just withdraw some of the blood in this syringe and just flush the whole system with that blood. So it really helps a lot in restoring the blood flow while no reflow has occurred. So what is your opinion on that, sir? Does it help?
I don't know. Saline flushes practically may just take some of the shower of thrombus burden into the distal vessels and may help in that sense, but practically it will be the coronary vasodilators. If we can deliver the vasodilators distally, I think your point is well taken. If we can deliver this drug distally into the coronary segments, that helps better, rather than just giving it into the ostium.
Right.
So well done, Amit. Very good case.